Well, I think we have sufficient membership around the table to get started with the last session here on HPV vaccine. And Dr. Bocchini will have you start things off.
Thank you, John. So I have the pleasure of introducing the final session for today, which is on HPV vaccine. This is a summary of the recent activities of the ACIP HPV vaccine work group. Over the last few months on teleconferences, we have reviewed the more recent data on the quadrivalent HPV vaccine in pregnancy registry. We've looked at long-term follow-up data that's becoming available on quadrivalent vaccine, and we've had some discussions concerning HPV infection risk for research HPV laboratory workers and HPV infection risk for selected healthcare workers as well. And we've been working on planning for updating our ACIP HPV vaccine statement. The plans for the statement go back to what we have out there currently. In 2007, there's our statement on use of quadrivalent HPV vaccine in women. In 2009, there was a policy note with the licensure of the bivalent HPV vaccine for use in women. And then in 2011, we updated the 2009 statement on use of HPV vaccine, quadrivalent vaccine, in males through a policy note. So the updated statement will need to include putting all our recommendations for men and women and boys and girls in one document, and reconciling a number of wording differences within the documents. In addition, adding updates on the burden of infection and cancers and changes in cervical cancer screening recommendations, updating vaccine trial data and safety data, and then addressing issues related to the research laboratory workers and certain healthcare workers as well. Additional future work group plans, we will look at data on alternative vaccine schedules. The data presented approximately a year ago on the study by Dr. Dobson and Associates was presented on to ACIP in June of last year. It is now published. There are other ongoing studies on alternative schedules, and we will be looking at all of those for potential future presentation to ACIP. And then our plans are to review new data when it becomes available from ongoing trials of current and second generation HPV vaccines. This session is really an informational session. We want to update the ACIP on a number of issues. First of all, the quadrivalent HPV vaccine and pregnancy registry. Merck has received notification from the FDA that they have met their post-licensure requirement for this registry. Dr. Fabio Lievano will present the data from this vaccine and pregnancy registry. Dr. Eileen Dunne is going to give further details about our plans for the updated ACIP statement. And Dr. Lori Markowitz will provide some information about the HPV vaccine program and some impact monitoring with data that she currently has from this country and elsewhere. So I'll turn this podium to Dr. Lievano.
Good afternoon. I'm presenting the Merck Pregnancy Registry for QHPV vaccine, Gardasil, exposure during pregnancy, June 1st, 2006 through May 31st of 2012. Gardasil is not recommended for use during pregnancy. There are not adequate and well-controlled studies in pregnant women. However, inadvertent exposures may occur. All spontaneous reports of exposure that meet the enrollment criteria when considered enrolled in the pregnancy registry, they were monitored closely by Merck and provided the most robust data. The pregnancy registry for Gardasil was part of a multifaceted plan to monitor the safety in pregnancy from approval in 2006. The registry was part of our regulatory commitment with the FDA, the EMA, and Health Canada at the time of approval. The main goals of the registry were to acquire information on pregnancy exposures and outcomes, to help identify safety signals, and to provide information to providers, regulators, and patients about exposures during pregnancy to QHPV vaccine. Data source for the registry were the pregnancy exposure spontaneously reported to the company through routine pharmacovigilance. Patients were considered enrolling the pregnancy registry if all of the following circumstances exist. The exposure was reported from the US, Canada, or France. There was a unique patient identifier. A healthcare provider was identified. The exposure occurred within 1 month prior to the date of onset of the last menstrual period, or LMP, or at any time during pregnancy. Instructions about how to make a report in the pregnancy registry were described in the label and in the website. The label and website also describe the criteria for enrollment. In summary, the data source for the registry consisted of the pregnancy exposures reported to Merck. These reports were voluntary and spontaneous, and were received from healthcare professionals or the females that were vaccinated. These reports were monitored as they were received. The reports were classified as prospective or retrospective. The prospective reports comprise the primary cohort of rate calculations. Prospective reports are those received before the outcome of the pregnancy is known. Retrospective reports are those received after the outcome of pregnancy is known. A report is classified as retrospective if an initial report is received after fetal testing identifies an abnormality. Because of the bias toward reporting abnormal outcomes, retrospective reports are analyzed separately from prospective reports. The primary outcome of interest are birth defects and pregnancy outcomes, including elective and spontaneous abortions prior to week 20, fetal deaths after week 20, and live births. Infant outcomes, including congenital anomalies, were also part of the pregnancy, and to identify the effects that might have been at birth. Pediatric medical records were requested for up to 2 years after birth for all newborns who have assigned maternal consent on file. Birth defect frequency were calculated on prospective reports using the MACDP methodology. This included the number of affected cases that included a live-born, fetal death, or termination after 20 weeks per 100 live-born infants. Finally, the annual report and selected cases were reviewed by appropriate experts as needed. And these are the results as of May 31st, 2012. 4,740 reports of exposure to QHPV vaccine during pregnancy were received by the company from market introduction, as I said before, to May 31st, 2012. 1,865 cases did not meet the enrollment criteria and were not enrolled. 2,802 patients with reports of exposure to QHPV vaccine during pregnancy were enrolled in the pregnancy registry. However, 73 are not included in this analysis because the estimated expected date of delivery is after the cutoff date. Of the 2,802 enrolled reports included in this analysis, 96% were received from the US, 1% from Canada, and 3% from France. There were 2,440 prospective report and enrolled cases. They are presented here in light blue on the left. 725, or 30%, were lost to follow-up. Of the 1,573 pregnancy outcomes, 5 were ectopic pregnancies, 1,452 were live births for a total of 1,460 newborns, because there were 8 sets of twins. 105 were spontaneous abortions, and 12 were fetal deaths. In regard to retrospective reports, and they are presented in dark blue on the right, 362 exposure to QHPV vaccine during pregnancy were received. 29 were elective abortions, 319 had pregnancy outcomes, and 14 were lost to follow-up. Of the 319 pregnancy outcomes for retrospective reports, 8 were ectopic, 242 were live births, 61 resulted in spontaneous abortions, and 8 were fetal deaths. These are the prospective reports, that is the primary analysis population. As I said before, in regard to the sport disposition, of the 2,440 reports, 30% were lost to follow-up, despite multiple attempts to enroll these cases in the registry. Less than 2% had a pending follow-up, and 69% had outcomes available. The patient age ranged from 11 to 42 years with a mean of 20 years. Approximately 91% of exposure were prior to the end of the first trimester. There were 102 elective abortions and 105 spontaneous abortions. In regard to outcomes, there were 1,460 newborns. 1,381, or 95%, were normal infants. 34 had an MACDP defined major congenital anomaly, and 45 had minor congenital anomalies. The overall rate of spontaneous abortion was calculated to be 6.7 per 100 outcomes with a confidence interval 5.5 to 8.2. The background rate among clinically recognized pregnancies is 15%. The rate of fetal death was calculated to be 0.8 per 100 outcomes with a 95% confidence interval of 0.4 to 1.4. In the general population, studies have indicated that the fetal mortality rate is approximately 0.62 to 1 per 100. The overall rate of major congenital anomalies was 2.5 per 100 live-born infants, with a 95% confidence interval 1.7 to 3.4. The background rate is 2.67 per 100 live-born infants. This table, that is very difficult to read, presents all the prospective reports, those received before the outcome of the pregnancy is known. Among the prospective reports of major congenital anomalies, 20 involve an isolated congenital anomaly. In this table, you can see the congenital anomalies occur in a variety of system organ class, and they are all different kinds of abnormalities. The most common reported was hypospadias with 3 reports, atrial septal defect with 2 reports, gastroschisis 2 reports, cleft lip and palate 2 reports, and talibs 2 reports. All other abnormalities were reported just once. There were 362 retrospective reports, or reports received after the outcome of pregnancy was known. Among the 25 retrospective reports of major birth defects, 13 reports involve an isolated congenital anomaly that include, for example, anencephaly, kidney malformation, unilateral talibs, congenital carat, spina bifida, hypospadias, amelia, or hydrocephalus. 4 had 2 anomalies each. 3 had multiple anomalies, and 2 had multiple anomalies as part of a chromosomal abnormality. This is the rationale for registry discontinuation. The pregnancy registry has fulfilled its regulatory obligation of collecting information for at least 5 years. The Gardasil Pregnancy Registry is one of the largest registries to date, with nearly 5,000 reports and 2,802 enrolled subjects until 31st of May 2012. As presented before, the data do not show clustering of malformations in any specific SOC. In addition, there is no identified pattern in terms of birth defects. The overall rate, including spontaneous abortions, fetal deaths, and congenital anomalies, are at or below background rates. The continuation of the registry will not significantly increase the power to detect adverse pregnancy outcomes. Now, in regard to ongoing and future activities, routine pharmacovigilance activities will continue for all exposure during pregnancy, and these include cases are reviewed in real time, follow-up attempts in all cases will continue, periodic aggregated analysis will be done, and the case report and analysis will continue being submitted to regulatory agencies. Merck has updated the website with text noting the discontinuation of the registry and the company continued interest in receiving reports of exposure during pregnancy. In addition, a summary of the overall result of the pregnancy registry will be added to the label. Merck will prepare a final registry report with all the data and publish the final data in a peer-reviewed journal. And in summary, the data from the registry are reassuring regarding the rate of spontaneous abortions, fetal deaths, and overall rate of congenital anomalies, and compares favorably to background rates. The review of the congenital anomalies appear consistent with background rates rather than as a result of vaccine exposure, and indicates that the anomalies are varied in type, etiology, and the gestational age of exposure. This review does not support a causal relationship between QHPV vaccine and the birth defects reported to the pregnancy registry. Merck had monitored the safety of Gardasil for over 6 years, including reports of exposure during pregnancy. And finally, FDA, EMEA, and Health Canada consider fulfill the Merck regulatory commitment. The website and letter to prescribers have been updated, and they are planning to update the label with the final data. Thank you.
Why don't we go ahead with any questions regarding the registry at this point in time? Dr. Keitel.
Thank you. Can you explain to me what the difference between the registry is and what you plan to do in the future if you're still going to submit each case and do aggregate analysis?
Absolutely. When we have the registry, we made several attempts calling the physician and really tracking down on these prospective reports. And also for 2 years, we were also asking for the medical charts to make sure that we get all the information. However, now with the future activities, we are going still to send letters to providers requesting more information, and we are going to continue writing in the periodic safety updates to regulatory agencies the reports that we received.
Do you happen to have the background rate for elective abortion in the general population? I think in your registry you had 102 out of 2,440 prospective cases.
Yeah, can I move to that slide? I think it's number 6. Number 6? Then slide number 6, please. Then number, thank you. Oh, this doesn't work. For elective abortions? That's the one you asked me?
Yeah, just curious in terms of whether or not a woman finding out that she was vaccinated would be more likely to terminate the pregnancy.
I don't have that rate at this moment.
Ms. Hayes.
In the United States, you're asking for how many women terminate a pregnancy in general?
Yeah, just the background rate of...
It's about a third.
About a third, so this is actually lower than expected. Thank you. Dr. Vasquez.
I have a question. In the congenital anomalies, did you look at whether most of them were first dose or second dose of vaccine? Did you?
Yeah, as I said,
I mean, there are a few cases, but
91% occur in the first trimester, and with the first dose, yes, I have that information.
so were these first dose recipients or?
Yes, 76%.
Okay.
Other questions or comment? Okay. Then I think we move on to
Thank you.
Dr. Dunne.
So good afternoon. I'll be discussing issues for consideration in the updated ACIP HPV vaccine statement. As highlighted by Dr. Bocchini, I wanted to just highlight some of the updated information for the statement. It will include updates to background information, HPV vaccine data, HPV vaccine safety data, as well as impact and cost effectiveness. Since the statement from 2007, there's been many changes that needed to be incorporated. Also in the updated ACIP statement, there'll be no wording changes for vaccine recommendation in pregnancy, but we will be making a change in the information about the pregnancy registry reporting. As you heard earlier, the quadrivalent HPV vaccine registry is no longer in existence. Providers and patients are encouraged to continue to report to VAERS and Merck, and the GSK pregnancy registry reporting remains the same. Also, for evaluations of child sexual abuse, the recommendation will be to start the vaccination series at age 9 years. So I'll be addressing the following issues today for the updated ACIP statement, including updated information on immunocompromised persons, consideration for vaccination of males through age 26 years for the medical indication of end-stage renal disease, and inclusion of information about select healthcare workers and HPV laboratory workers. So there have been new data on HPV vaccine in HIV-infected persons published, and there are now 1 clinical trial in men, 2 in women, and 2 in children, and these studies have demonstrated an acceptable safety profile and good immune response to vaccine. And some studies have found differences in the geometric mean titers of antibody to HPV compared to historic controls. However, it's unclear if this finding has clinical significance. And for other immunocompromised populations, such as persons post-transplant or persons with autoimmune disorders, there are ongoing evaluations. So we propose including these updates in the revised statement and ensuring harmonization of male and female recommendations. So I'd like to next discuss the proposed changes in the medical indications for the current adult schedule for HPV vaccine. So I wanted to highlight the current schedule for various medical indications and focus your attention on HPV vaccine recommendations for males and females, which is noted as the 4th and 5th listed vaccine here. For males, vaccine is recommended through age 26 years for those with HIV infection, those with other immunocompromising conditions, and men who have sex with men. For the medical indications including heart disease, asplenia, chronic liver disease, kidney failure, diabetes, and healthcare personnel, the recommendations are the same as for the general recs for males through age 21 years. So we conducted a review of the literature on these specific medical indications and HPV-associated disease and cancer. And we found there was data that there was a higher burden of HPV-associated diseases and cancer for only one of these medical indications, kidney failure. We proposed extending vaccination for males through age 26 years for this medical indication, and this would mean inclusion of this information in the updated statement as well as a change in the medical indications schedule. The reasons to extend to age 26-year-old males for this specific indication are that data show a higher burden of HPV-associated diseases, including anal genital warts and cervical dysplasia. For both end-stage renal disease patients, as well as those post-renal transplant. And although this is primarily descriptive data, there's no data on vaccine efficacy specific to this population. Quadrivalent vaccine is licensed and safe through this age. And another point is there is likely to be a benefit to vaccination early, especially since many young persons with end-stage renal disease will eventually receive renal transplant. And as a note, we already recommend vaccination for persons post-transplant through age 26 years. So next, I'd like to discuss the question of HPV laboratory workers and select healthcare workers. And we posed these questions listed here, including, is there a risk to HPV laboratory workers of acquiring HPV from wild-type virions and newer synthesized virions? Also, we posed the question about the risk to healthcare workers of acquiring HPV secondary to surgical smoke. The second issue was also considered for the STD treatment guidelines meeting in April of 2013. So for the first question about laboratory workers, it's important to note that HPV is difficult to culture, and PCR for DNA is often used to evaluate for infection. Some research laboratories are working with wild-type HPV as well as newer synthesized virions to characterize the natural history and immunity to HPV. And there are over 6 U.S. laboratories and other global laboratories in which these lab-generated virions are being produced. There are 2 types of virions used in the lab. There's the wild-type HPV, which are generated in the lab by infected xenografts grown in immunocompromised animals or transfected keratinocytes in organotypic raft cultures. And the generation of these virions is time-consuming and produces very low virus yields. But some newer techniques recently introduced allow development of lab-generated virions called pseudovirions or quasivirions. And pseudovirions are simply, they simply have the capsid proteins encapsulating a reporter gene, and they have no oncogenes, and they're not believed to be infectious. And so for the purposes of this discussion, I will not talk about these virions further. However, another synthesized virion called quasivirions are lab-generated and synthesized in the 293TT cell system, and they consist of the capsid proteins, which encapsulate the complete 8-kilobyte papillomavirus genome. And they are generally indistinguishable from tissue-derived or wild-type papillomavirus. So this is a simple illustration of how these virions are created through transfection of the genome with the capsid proteins in the 293TT cell system. And within 72 hours, the virions are produced and purified. And the synthesis of these quasivirions produces 1,000 times more infectious virus per cell culture than organotypic culture systems. Wild-type and quasivirions are infectious, and this has been demonstrated using animal models in which rabbit papillomas were produced when these virions were injected in the skin. And these virions contain whole HPV genomes, including oncogenes and other elements associated with disease and cancer development. For quasivirions, as I highlighted earlier, the cell system produces very high titers of virus, over 1,000 times more than the wild-type systems, and up to 10 to the 9th transducing units from a single flask. It's important to note that the minimal infectious dose is not known. Some of the potential exposures that could happen in the laboratory include exposure through mucosal, cutaneous, or respiratory routes. And although there are known high virion titers of quasivirions in the lab, the potential risk to lab workers has really not been characterized. There's no evidence of previous exposure, infection, and disease in the laboratory, although this is somewhat difficult to assess. There's been inoculation in rabbits using these virions that did demonstrate disease, as I noted earlier. So just to summarize, there's a potential risk of HPV acquisition to research HPV lab workers working with these quasivirions and wild-type virions. However, there are limited data on risk and no data on transmission or vaccine efficacy for these potential exposures. And we propose adding language for inclusion in the updated ACIP statement, and I'll discuss this language at the end of the presentation. So for the second question, is there a risk to healthcare workers of acquiring HPV during treatment of anogenital lesions? 7 studies have collected smoke plumes after therapy for warts or cervical intraepithelial neoplasias that demonstrated intact HPV DNA. And one of these studies also looked at electrocautery. There's evidence from an animal model that these virions from the smoke plume are infectious. And finally, there are 2 case reports of laryngeal papillomas reported in healthcare workers who treated persons with anogenital warts. Although the timing of disease development is consistent with this being the exposure, it's unclear if RRP was a result of this exposure. So one study evaluated smoke plumes generated from laser CO2 of papillomas in cows, and the smoke plume was suctioned and collected and re-inoculated in the skin of the calves, and all these plume samples were positive for bovine papillomavirus, and all calves developed fibropapillomas at the site of inoculation. It's important to note there's current infection control practice recommendations. NHIS has issued guidance on using local exhaust ventilation or a smoke evacuator when these methods are utilized. And this is the language that they have. So in summary, smoke plumes generated by electrocautery and laser CO2 can contain infectious papillomavirus. Current recommendations include use of a smoke evacuator. Although there are 2 case reports in the literature, it's unclear if this potential exposure led to the disease, and there's limited data on risk and vaccine efficacy in this setting. And we propose language for inclusion in the updated ACIP statement. And I'd like to share that draft language with you and read it to you. Research HPV laboratory and select healthcare workers might have an increased risk of acquiring HPV from occupational exposures. These persons include those working in laboratories and handling wild-type virus or quasivirions, and healthcare workers treating anogenital intraepithelial neoplasias or anogenital warts with laser CO2 or electrocautery. In the laboratory setting, proper infection control should be instituted, including at minimum of BSL-2. Healthcare workers treating anogenital intraepithelial neoplasias or anogenital warts with laser CO2 or electrocautery should have vacuum ventilation as recommended by NIOSH. And the need for any additional infection control steps in these settings is being investigated. It's unclear if there would be a benefit of HPV vaccination in these settings, as there are no data on transmission risk or vaccine efficacy. And I'd be happy to hear comments on that draft language, and I wanted to thank those that contributed to this assessment.
Thank you. Dr. Harriman.
I have a question about the surgical smoke. I would like there to at least be some consideration of language about respiratory protection for healthcare workers doing those procedures. That question has come to me quite a few different times. It seems reasonable, an N95 or higher respiratory protection, but I just wondered if you had discussed that.
Yeah, it's a great point. We have been discussing potentially other infection control practices such as personal protective equipment with our Division of Healthcare Quality. And we are having sort of active conversations about other steps that may or may not be needed. At this point, so that's under consideration. Thank you.
Dr. Sawyer.
2 questions related to the healthcare worker recommendation. First, do you propose any age restriction on it? I would assume not. And secondly, I'm wondering about the recommendation that only healthcare workers doing these specific types of surgery are included. I would imagine people could be asymptomatically infected or infected without an obvious lesion, and that people doing cautery in the anal genital region in general might be at risk. And do you know anything about that?
So let me, just the first question, or let me go to the second question about other kinds of exposures to smoke plume. Is that what you were?
Yeah, from any surgery in the anal genital region, not just on intraepithelial neoplasias or genital wart.
That's a good point. Most of the cases, as I described, the kind of evaluations primarily occur with anogenital warts and CIN, but there could be other areas of the anogenital mucosa that will also use those techniques, so it's a good point. And I'm sorry, what was your first question again?
Whether there'd be any age restriction on the
So this draft language is primarily for informational purposes, and it would be included in the draft statement, but there would be no specific vaccine recommendations.
Dr. Kaiserlin.
Yep, Harry Keisling from Shea. Would you consider extending this to oral cancers or other cancers that are probably HPV related in terms of healthcare worker exposures?
That's a great question about other kinds of treatments of other types of conditions. I guess the question I would need to address is whether these kinds of procedures are being used for oral cancers, and I'm not clear about that. So we can address that and follow up.
Well, and particularly for ablation of lesions, laryngeal lesions, I'm sure that causes smoke.
Yeah, I will definitely follow that up with the group that works with cancers, and we can consider that as well.
Dr. Campos-Elcote.
What's being proposed on males for those with kidney failure and end-stage renal disease? Because I don't see any wording for that. Are we voting on something on that? We're not today. That's going to be considered? Is that?
What we were proposing is extending just the medical indications for kidney failure through age 26 years for males for that specific medical indication. But no, we don't have a vote at this meeting.
So are we, I mean, is that a vote plan for the future, or is that just going to be inserted as, I mean, is that a decision that's been made, or is that a decision that's pending?
This session was primarily to present our information about what we were proposing. I think it will be up to others to consider whether a formal vote will need to be considered for that indication.
At this point, I think it's informational. The question is whether or not this is an expansion to the level of which requires a vote for recommendation or not. And I think that's something we may want to discuss. Dr. Cohn-Beasley.
I can assure you it'll be something that the Adult Immunization Work Group will discuss, and clearly in conjunction with the evidence presented by the HPV Work Group, which I'm on both.
Dr. Bocchini.
I was going to say the same thing. That would come before the committee for its consideration as the statement is updated.
Procedurally, I'm confused.
Well, I think the purpose of this is informational and also to get feedback from the committee in any specific areas that should be further investigated. Is that?
Yes.
Summarizing?
Thank you.
So I think technically, if it is a recommendation we make, we probably should have it as a motion and seconded and voted upon, if indeed that is an if you can inform us, Dr. Shugat.
Yeah, my understanding was, can you turn yours off or something? I think today was, I think somebody needs to turn that one off. Or I understand that I think the group was trying to catch the committee up on all of the issues they've been talking about. So it's a good time if you have questions about the best ways they should be thinking or considering the end-stage renal disease to propose them, but that it would be at a future meeting where decisions about any substantive changes would get voted on. So this isn't to say we're not ever going to vote. It's to say the committee's still working and wanted to update you on a lot of issues, or the working group is still working.
I see this as very similar to the MMR group that looked at new data regarding, for example, HIV-infected individuals, people on high or on heart, and so on, and was presented once or twice prior to the time that it was all put into a package, and each of those components were voted upon. So hopefully this is going to be, I think it's heading in the same direction. Yeah, Dr. Keidel.
So presumably, before it came to a vote, the committee would be briefed on the risk, how high the increased risk is, whether there are certain subgroups of end-stage renal disease, do they have other risk factors that predispose them to these diseases, so on and so forth, before they would vote.
Dr. Bocchini.
Yeah, the committee would certainly bring forward the evidence and they set specific recommendations at the appropriate time. So, yeah.
Dr. Riley.
I have a question getting back to the pregnancy issue. You had mentioned that you're not going to change the language, but would you consider, given the sort of positive news that we heard about Gardasil, would you consider a statement such that, if there is an inadvertent, pregnancy in the course of vaccination, to not do an elective pregnancy termination? I mean, sort of along the language of MMR?
That's already included.
Okay, so
yes.
It's strengthened, okay.
Yes.
I'm wondering, too, if we could get a guesstimate of the number of laboratory personnel actually involved. I think the number of people involved or potentially exposed to smoke from vaporization is not uncommon, but the number of people who work in these 6 laboratories, I would guess, can be counted on a couple hands.
Yes, that's correct. And one other follow-up point is the BMBL is also going to be evaluating this is a new technique, the synthesis of quasivirions, and so BMBL is also going to be considering this in the future.
Yeah, Dr. Rubin.
Yes, in terms of the end-stage renal disease, is the burden of disease mostly the sort of anogenital warts, or is it more cervical dysplasia? Because that has implications about which vaccine is likely to be more effective for prevention of those.
That's a great question. And I think in my slide I did highlight that most of the data in end-stage renal disease is primarily descriptive data. It's primarily of anogenital lesions, such as anogenital warts, but there's one description of cervical dysplasia. There's no information on rates or incidence calculations, and there's no data on vaccine efficacy in this particular group, although there are ongoing studies, I believe, that are being conducted in this population.
Yeah, Eileen, we've heard data about the durability of MCV4 and Tdap not being what we thought it was. Can you give us the latest on the durability of HPV antibody?
Yeah, I think we have data that has been presented before the work group out through about 6 to 10 years, depending on the vaccine, that show immune response to vaccination. Is that what you were referring to? Okay.
Any additional questions? Then I think Dr. Markowitz.
So to close this session, I'm going to review the HPV vaccination program and impact monitoring. And I will review a variety of topics very briefly. Some of these data the ACIP have seen before, and they've been updated. First of all, the vaccination program, very briefly, I'll review a very brief update on vaccine safety, and then talk about vaccine impact monitoring. So this is a review of our recommendations in the U.S., which I think you all know, that ACIP recommended quadrivalent vaccine for females 11 or 12 years in 2006, and through age 26 for those who are not previously vaccinated. And then in October 2009, after the bivalent vaccine was licensed, ACIP revised recommendations to state that either vaccine could be used. In 2009, also, the quadrivalent vaccine was licensed for use in males, and at that time, a routine recommendation was not made, but in 2011, ACIP recommended quadrivalent vaccine routinely for males 11 or 12 years and through age 21. And shown in this slide, which again I think you have all seen, are data from the National Immunization Survey Teen from 2006 to 2011 for all adolescent vaccines. As of 2011, 78% of adolescents had received Tdap, 70% had received meningococcal conjugate vaccine, and in contrast, only 53% of girls had received one or more doses of HPV vaccine, and 35% had received all 3 doses. And as also you can see here, each year there was about a 10 percentage point increase in coverage for Tdap and meningococcal conjugate vaccine, but for the past 3 years we've seen very little increase in coverage for HPV vaccine. Vaccination status as well as intent to receive vaccine among parents of unvaccinated girls are also available from the NHIS surveys. And shown here is the total population of girls for the survey years 2008 to 2011. And each year the proportion of vaccinated girls has increased, shown in pink, and subsequently decreasing the proportion who report they are somewhat or very likely to have their daughter vaccinated. And the proportion of parents who report that they are not likely to receive, for their daughter to receive vaccine in the next 12 months has remained relatively constant at about 25%, shown in blue. And we don't know if this means that they are never intending to vaccinate their daughter or they are waiting for some time in the future. In 2011, the top 5 reasons for not vaccinating their daughter among parents who said they had no intention to vaccinate in the next 12 months were feeling the vaccine is not needed or necessary, their daughter is not sexually active, they had safety concerns, lack of knowledge about the vaccine, and no recommendation by a provider. Now, while NIS teen survey collects data on 13 to 17-year-olds, the National Health Interview Survey collects data on older individuals. And in contrast to the National Immunization Survey, NHIS vaccination history are from self-report, where NIS data are from provider-verified records. And here you can see coverage in 2010 and 2011, at least 1 dose coverage in women aged 19 to 26 increased from 20.7 to 29.5, and the largest increase was in 19 to 21-year-olds, where coverage increased from 28.2% to 43.1%. And age at vaccination is actually not collected in the survey, so it's unclear if the vaccination occurred as an adult or whether or not they were part of the adolescent program and then just aged into this cohort. Now, a brief update on vaccine safety. Again, I think everyone knows here that updates on vaccine safety have been provided periodically to ACIP. As for other vaccines, the Immunization Safety Office safety monitoring infrastructure has 3 components, which is the VAERS system, the vaccine adverse events reporting, VSD, or the Vaccine Safety Data Link, and the Clinical Immunization Safety Assessment, or CISA, and a brief description of each of these is on the slide. About 56 million doses of quadrivalent vaccine have been distributed or were distributed in the U.S. between June 2006 and March 2013. No new safety concerns have been identified in recent analyses of the post-licensure safety data among males or females. Among the 7.9% of reports to VAERS that were coded as serious, the most frequently cited adverse events are headache, nausea, vomiting, fatigue, dizziness, syncope, and generalized weakness. And the pattern of these reports, both serious and non-serious, are consistent with those reported in the summary that was published after the first 2.5 years of VAERS data. And syncope continues to be a frequently reported event in adolescents. Now, of note, in this slide, we show the adverse events reporting to VAERS following quadrivalent vaccine administered to females, and you can see it steadily decreased over time after 2008. Also shown here are the proportion of all events that were serious events, and these have also declined from the peak in 2009, where they accounted for 12.8% of all events, to only 7.4% in 2013. In terms of the vaccine safety data link, to date, more than 1.8 million doses of HPV vaccine have been administered to patients within the VSD network. That's quadrivalent vaccine, about 270,000 to males, and the Immunization Safety Office was waiting to a large enough number had been administered to males to start their rapid cycle analysis, and that will begin this year. As previously published in a rapid cycle analysis study carried out in 7 HMOs among over 600,000 doses to females 9 to 26 years of age, there was no statistically significant increased risk for any of the pre-specified adverse events which I've listed on the slide. And the longer-term surveillance of GBS and stroke among females 9 to 26 years of age following quadrivalent vaccine was evaluated after 1.5 million doses, and no increased risk was observed, and those are in the process of being written up at the present time and will be available in a publication. As you heard earlier today, there were no safety concerns raised by the Vaccine and Pregnancy Registry for the quadrivalent vaccine. CDC and FDA will continue to monitor the safety of HPV vaccines, including reports in pregnant women through VAERS, and we also heard that Merck will continue to collect this information as well. A retrospective analysis of pregnancy-associated VAERS reports is in progress. Since about 85% of reports submitted to VAERS are submitted through the Merck vaccine registry, pregnancy registry, it's anticipated that there will be a very similar safety profile that's found as was reported by the Merck pregnancy registry. And for VSD, there's a descriptive study looking at adverse events following inadvertent exposure to HPV quadrivalent vaccine during pregnancy, and those data will be available by 2015. Now I'd like to turn to HPV vaccine impact monitoring. For impact monitoring, it's very helpful to consider early, mid, and late outcomes based on when we would expect to see outcomes based on the natural history of HPV vaccine. So early would be HPV prevalence in genital warts in teens and young adults. The mid outcomes would be the precancer lesions, and the late outcomes, which we may not see for some time, which will be the impact on cancer. And impact monitoring is occurring in a variety of countries, and data are available from countries that were early adopters of HPV vaccine. Before I talk about data from the US, I'd like to show data from a few other countries. Specifically, I'll focus on Australia and Denmark, but there are data from a variety of other countries that are available, and some of which have been published. Australia introduced their vaccination program in 2007 as a school-based program. This was publicly funded using quadrivalent vaccine, and the target age group was 12 to 13-year-old girls. They also had 2 catch-up programs that lasted for a 2-year period. One was 14 to 17-year-olds in schools, and the other was 18 to 26-year-olds in the community that was administered by primary care providers. And they achieved coverage of over 70% for 3 doses in the school-based program, and about 51% one-dose coverage in 20 to 26-year-olds, somewhat lower coverage in some of the other catch-up age groups. We presented these data before, and this is an update of this. But Australia was the first country to publish data showing an impact of the vaccination program looking at genital warts in 6 sexual health centers across the country. And these data, which I'm showing you today, are from a more recent publication from this year. And shown here is the proportion of females diagnosed as having genital warts at their first visit by age. And you can see here in the solid green line, which are those under age 21, that there was a fairly dramatic and early decrease in genital warts. And through 2011, there's been a 93% decrease compared to the pre-vaccine era. Among those 21 to 30, there was a 73% decrease shown in the dotted red line, and there was no decrease seen in those over age 30. Data from Australia also demonstrated a decline among males, although males were not included in the vaccination program. You can see here the most dramatic decrease again was in those under 21, shown on the solid green line. And this was a strong demonstration of herd immunity from their vaccination program. Australia has also demonstrated declines in vaccine type prevalence among 18 to 24-year-old women. And this slide shows from left to right any HPV prevalence, high-risk types overall, non-vaccine high-risk types, and then on the far right, vaccine type HPV prevalence. And there was about an 80% decline in the prevalence of vaccine types within 3 to 4 years after introduction of the vaccination program. Now, a brief review of the data coming out of Denmark. Denmark introduced vaccine in 2009. Vaccine was delivered by general practitioners. This was also publicly funded using quadrivalent vaccine, and the target age group was 12-year-old girls. They had a more limited catch-up program of 13 to 15-year-old girls, and it's actually started slightly before their routine introduction in late 2008. And through this general practitioner organized program, they achieved greater than 80% three-dose coverage in both the target age and the target and the catch-up age groups. And these are the data that were just published this year from Denmark. These are data on genital warts from the Danish National Patient Registry. The slide shows national data by 6-month interval from 2006 to 2011 for 12 to 21-year-old girls and boys, men and women, I should say. The incidence was low for those 12 to 15. Among those 16 to 17 years, incidence peaked in the second half of 2008, and that was followed by a sharp decline. The decline went from 381 per 100,000 to 40 per 100,000 in the first 6 months of 2011. There were also more gradual but significant declines in women in the older age groups. And among men, as you can see, there was no significant decline in genital warts, but there was a tendency for a decline in some men in the older age groups, which I have not shown on this slide. The average annual percentage change was 45% for those 16 to 45 years of age among women. Now, turning to the U.S., we have a variety of efforts ongoing to monitor the impact of HPV vaccination. This includes type-specific prevalence, genital warts, cervical precancers, and HPV-associated cancers, and I'll show some of these data. The first data are from NHANES, the National Health and Nutrition Examination Surveys. This is a representative survey of the U.S. population. There are both home interviews and examination in a mobile exam center. HPV component of this includes women initially and now men as well, 14 to 59 years of age. HPV DNA testing and self-collected cervical vaginal swabs was added to the survey in 2002. Demographic and sexual behavior is collected as well. HPV vaccine questions were added in 2007, and this year we added HPV DNA testing for males. We will not have those data till 2015. This slide shows the prevalence of vaccine-type HPV in females by age group in the pre-vaccine era shown in orange and the vaccine era shown in green. And as you can see, there was a significant decline found in 14 to 19-year-olds, and this, of course, is the age group in which we would first expect to observe a change, and there were no significant differences in HPV vaccine-type prevalence in the other age groups. Among 14 to 19-year-olds, there were no changes in the population characteristics that could have contributed to this decline, such as the percent sexually active or the number of lifetime sex partners or race ethnicity. And of course, this point estimate decline of 56% is greater than we would have expected based on 3-dose vaccine coverage in the U.S. Now, this decline could be due to some changes in behavior that we were not able to measure, but the data likely demonstrate early impact of vaccination and suggest impact from herd immunity or efficacy from less than a complete 3-dose schedule. Early impact of the vaccination are also suggested by some data we have on genital warts. We have a variety of projects looking at genital warts, and the one I'll present today is the administrative data that we have from the market scan data. This analysis that I'm going to show you now is from the market scan commercial claims and encounters database from 2003 to 2010. We showed earlier years to you previously. The objective was to estimate the annual prevalence of anogenital wart diagnoses from 2003 to 2010. This looked at persons 10 to 39 years of age who were continuously enrolled and includes over 64 million person years of data, and cases were defined by ICD-9 codes as indicated here on the slide. So these are the data for females, and you can see here at the very bottom, the lowest prevalence was in 10 to 14-year-olds and the highest to 20 to 24-year-olds, consistent with many other studies looking at genital wart prevalence. And in red, you can see the line for the prevalence in females aged 15 to 19, and there was a significant decline from 2.9 per thousand in 2006 to 1.8 per thousand in 2010. Women aged 20 to 24, prevalence increased from 4 to 5.5 in 2007 and then remained level through 2009, and you can see there's starting to be a decrease in 2010. There's also maybe a suggestion of a decrease as well in 25 to 29-year-olds. These are the data for males. And here you can see that in contrast to the females, prevalence increased or was stable during this time, and there was certainly no decrease seen in the 15 to 19-year-olds. Among 20 to 24-year-olds, prevalence increased through 2009, and there was a small decrease. These data will be further evaluated, but the early decrease in 15 to 19-year-old females, as well as trends in some of the other age groups, do suggest an early impact of vaccination. Several evaluations are ongoing to evaluate MID outcomes or cervical precancers, and today I'll just show you some data from our population-based assessment in our Sentinel sites in the Emerging Infections Program. Since precancer lesions are detected by cervical cancer screening, changes in cervical cancer screening recommendations will impact our ability to interpret these findings. This is particularly an issue for the youngest age group, since recommendations have changed so that screening is not recommended before age 21. So the project, our HPV Impact Project, which is being conducted in the Emerging Infections Program, is monitoring vaccine impact on high-grade cervical lesions. It's being conducted in 5 sites, and data are collected on CIN 2, 3, and AIS directly from histopathology labs. HPV typing is being conducted at CDC, and vaccination history is actively being collected from a variety of sources. We're still analyzing data on rates because, as I mentioned, we needed to collect information on cervical cancer screening to adequately interpret these. So what I'd like to show you today is a previously published data looking at the early impact of vaccination, and here we're looking at the percent of CIN2 lesions due to HPV 16 and 18 among those unvaccinated and those that are vaccinated, analyzed by time since PAP that led to the biopsy for that diagnosis. And time between PAP and vaccination reflects the likelihood of being vaccinated before exposure to the type that was responsible for the precancer lesion. And here what you can see, as expected, is that those vaccinated in the recent past were not less likely to have HPV 16-18 related CIN compared to those unvaccinated. However, for those vaccinated more than 24 months before their PAP, they were significantly less likely to have HPV 16-18 related lesions compared to those unvaccinated. And finally, in terms of late impact, we will be able to look at cancer. We have cancer registries in all states that cover virtually 100% of the population. Regular updates on HPV-associated cancer overall and by state will be reported. And the first report was published in the MMWR last year. Typing of these cancers has been done in select registries as a baseline, and these will also be reported to look at type-specific cancers. So in summary, vaccination coverage has increased since 2007, but very limited increase has been observed in recent years. Post-licensure monitoring data continue to show a good vaccine safety profile. A variety of early, mid, and late HPV-associated outcomes are being monitored, and data suggests impact on early and mid outcomes in the United States, despite our low coverage. I wanted to end with mentioning some plans that CDC has. First of all, we have an HPV-specific MMWR that's scheduled to come out in July. This will have data from the NHIS teen from 2007 to 2012 and also summarize vaccine safety data. The annual NHIS teen MMWR will come out at the end of August. This will have 2012 data on coverage. There's work going on to utilize the information immunization systems to conduct reminder recall and vaccination coverage assessment of providers reporting to IIS. A variety of tools are being developed for providers, including a tip sheet for talking with patients about HPV vaccine. There's a speakers bureau that's being developed. And there's continued effort to evaluate barriers to vaccination, understanding what safety concerns truly means, since this has been reported as one of the reasons for non-intent to be vaccinated, and then further communication of safety data to providers and parents. And I want to thank a large variety of people who contributed data for this presentation.
Thank you. We're open for any questions. Comments? Ms. Hayes.
I think, sometimes we all get lost in the details. I had a question about men and the increase in oropharyngeal cancer and what the discussion is in the working group on looking at vaccinating men over age 26. Did I miss that earlier, or was it just not mentioned?
We have not had any discussions about vaccinating men over age 26.
Dr. Salisbury.
Yes, thank you, Laurie. You expressed some surprise at the impact on genital warts being greater than the coverage might have predicted, looking at 3-dose coverage. And I wondered if you'd analyzed it by 1-dose and 2-dose coverage, because you may only need 2 doses.
Well, the data that I showed from the MedStat market scan data, we do not have, right now, there's no vaccine data associated with that, with just an ecologic analysis. For the NHANES data, where we're looking at prevalence, we do have self-reported history of vaccination, but our numbers right now were too small. We did not want to break it down by individual number of doses, but that is something we'll be looking at.
Dr. Schuckett.
Yeah, just a comment. Thanks, Lori, for a really nice summary. We spent a lot of the day talking about a teenage vaccine which has performance that is disappointing at this point, but we've had very good uptake and are really on track. In fact, have achieved the Healthy People 2020 objective for that vaccination of teenagers. And here we're finding out about a vaccine that has greater than expected performance, even with our pathetic coverage. And I think that this audience of highly motivated immunization experts and clinicians and program staff, I hope see this as a wake-up call for us to do much, much better, because we started off, Lori, if you could go back to that coverage slide, every time I look at that, I'm struck with the fact that in 2008, the 3 vaccines first dose coverage were neck and neck. We had a really good initial program for HPV. I think it's slide 4. Really expecting pretty good things. And since 2008, they have diverged in a major way. And I think this is a a point where these vaccines are working better than we thought. They're safe. They appear to be extremely effective. And as clinicians, parents, and community members, I really think we need to do better in getting them to girls to prevent the cancers that will be occurring if we don't do better.
Dr. Sawyer?
I'm wondering if your coverage rates may be a slight underestimate. In California, we have a new law that allows minors to consent for prevention services for STDs, which includes HPV vaccine. That may lead them to get the vaccine at someone other than their primary care provider and maybe not report it or have it not as easily reported. Do you have any idea of the impact of such practices?
Let me refer that to Shannon Stokely, or I guess she's saying we don't. The answer is
well, if I recall correctly, that law was just recently passed, or it was within the past year.
No, that's true in California. I assume
Yeah.
there must be some other states that have similar laws, though, that have been longer.
Very few states have that specific law tied, because you have to have the word prevent STD in the law, and that's usually the key. But as you said, if teens are obtaining vaccines outside of their routine medical provider and not letting their parents know, because the NIS teen survey is with the parent, and so the parent has to indicate where the child got the vaccine for us to validate the immunization history. So if that's missing, then yes, we would be underestimating. But so I really can't say how frequently that's occurring. But I imagine with HPV, I don't think our rates would be dramatically higher if we had that.
Dr. Hahn?
Yes, it seems to me that I think we all recognize that that some of this is probably a hesitancy of sort of too soon at age 11, 12. And I'm wondering, as I think about reasons to motivate parents and providers that age 11, 12 is a good time to get this vaccine done. There was some data presented in a previous meeting that younger adolescents respond better to this vaccine, at least serologically, than the older adolescents. Has that information, and maybe it's premature, maybe we don't know exactly what that means, but is there a way to turn that into a message of why it's better to vaccinate younger adolescents?
I think we have been discussing that. That is included in a lot of our communication messages, that the immune response to vaccination is better at the younger ages. So we have included that in some of our communication messages. Maybe we need to evaluate if the providers understand that and if that's communicated. That's something we could look at.
Dr. Bennett.
I had another question, but I'll ask this one instead. Lori, could you talk a little bit about how we are going to deal with the decreasing rates of screening and their impact on looking at the intermediate outcomes?
Well, we are, in the sites where we're doing the monitoring for the precancer lesions, we are trying to get estimates of screening rates. Now, this is difficult in the U.S. because we don't have national PAP registries. There's only one state that has a state registry, so we're being creative and trying to collect data from a variety of sources. This is very challenging, as it is to get vaccination history, since we don't have complete vaccine registries. But I think we're going to be trying to do that, and we have incorporated it into some of the analyses. But is one of the challenging aspects of looking at the precancer lesions, and that's why I think that having some of the HPV type-specific data is going to be helpful.
Dr. Turner.
Jim Turner, American College Health. In answer to Mark Sawyer's question, in 2011, we had 3 schools representing the states of Wisconsin, Pennsylvania, and Virginia look at immunization rates among females who had matriculated our schools, and we were at 46% uptake for 3 shots among females who were in college, and obviously different socioeconomic climate, and each state has different rules. But in Virginia, we have a permissive recommendation for 6th graders to get it, and I believe minors can sign for it and get it if they have a way of paying for it. Regarding the age of uptake, and by the way, I think cost for a lot of people remains a big issue, and hopefully with the Affordable Care Act, that's going to become less of a burden. But we've got a network of colleges contributing data to us, and among 20,000 vaccines given for our network of 22 schools, about a quarter of them are still being given to males, and 60% of the males receiving the vaccine are actually over the age of 21. So there remains a fairly, and this is with no marketing, by the way, and no recommendations, so there remains a fairly robust demand among men to receive the vaccine over the age of the recommendation. Thank you.
Dr. Lahr.
Jamie Lahr from the AAFP. Could you please remind me how much more effective the vaccine is when given to younger, like 11 and 12-year-olds versus older adolescents? I'd like to pass that on to the AAFP members.
Well, first of all, the efficacy trials were only done in women 15 to 26 years of age. So the efficacy data comes from that age group. And then the bridging immunogenicity studies were done in the younger age group, the 9 to 15-year-olds. And so what was referred to earlier is the data showing that the antibody titers are higher in the younger age group compared to the antibody titers that were in women who were in the efficacy trials. So, I mean, the efficacy, if someone is naive to a vaccine type, the efficacy was close to 100% in those older women. So the efficacy was very good, and we don't think the efficacy is going to be different. We're talking about the immune response to vaccination being higher in the younger age group.
Other questions or comments? Dr. Bocchini and then Ms. Hunt, or Ms. Hayes. Ms. Hayes first. Oh, Dr. Bocchini wants the last word, so Ms. Hayes.
I gave you an erroneous statistic earlier. The abortion rate in the United States has dropped to 22%.
Thank you. Dr. Bocchini. Oh, Dr. Bennett.
So you can have the last word. Just one last question. Has there been any consideration of school-based strategies for delivering this vaccine?
Dr. Shuckett.
Yeah, there are a couple comments. There are some programs that are offering, school-associated vaccination for a variety of vaccines. But one thing that's really has struck us in looking at the data over the last few years is that the very high coverage with Tdap and meningococcal conjugate has not been delivered through schools. That's been delivered primarily through the medical home. And so when we analyze our data for missed opportunities, if every time a teen was getting a Tdap or a meninge vaccine, they were offered and accepted an HPV vaccine, our first dose coverage could be 90%. So the question of whether school strategies are needed or even cost effective here in the US, now that we have a pretty strong adolescent platform to build on, we think we can do this with the medical home if the clinicians will make strong recommendations. We also have had some disappointing results in some of the school programs for flu and for other vaccines, and so while that is a way to reach some people, we think the medical home is probably the way to go for this.
I'll just toss out too, across my state we have one school nurse per 1,950 students, and they spend all their time pushing stimulant medication and going on field trips with diabetics, and there's just no time for anything else at this point in time. Dr. Bocchini.
Yeah, I just wanted to recognize Dr. Markowitz, who's been the designated federal official for the HPV work group since its inception, and all the contributions she's made to the work of the committee. And also want to thank the committee members who have really worked hard over the years to bring us to this point and continue to do so.
I have both some good news and actually two pieces of good news. Number one, We are close to finishing, but the other piece of good news is Dr. Gillen and Dr. Ornstein are here and are able to give agency updates, and they assured me these would be brief. We also, as of this point in time, have no public comments, so we'll let Dr. Ornstein and Dr. Gillen have the last word.
Would someone bring up Walt's slide set, please?
Are we going to rush through? We can start with slide 30. The NVAC met on June 11th and 12th. It's actually a 25th anniversary of NVAC. First meeting was in June of 1988. And unfortunately, a few of us were there at that time and have aged. A major focus was on adult immunization, and two action items really came out. One, the National Adult Immunization Summit has proposed a major revision in the standards for adult immunization practices, something NVAC issued in 2003. And we have that draft, and we'll be reviewing it and hopefully supporting soon a new version, which I think is much more comprehensive and audience-based than the current version. The second issue is we heard a lot about adult immunization and in a sense, the sorry state of affairs with regard to implementation. And we've asked the National Vaccine Program Office to come back to us as to how we can be helpful. We've already issued in 2011, published in 2012, a comprehensive set of recommendations and determine what else we might do to move things along. A third issue is what was reported, I guess, at the Adult Immunization Summit is CMS has recommended withdrawal of a requirement for a performance measure with pneumococcal vaccination. We will be having an urgent meeting of NVAC by telephone on Friday to discuss the proposed CMS rule to remove that measure and whether NVAC should or should not make any recommendations with regard to that. The other big issue is we have a number of working groups. I think Ann and others have gotten the message across very clearly. We're not doing well on HPV vaccine implementation. And we have formed a working group chaired by Sarah Dupre and Wayne Rollins, charged by the Assistant Secretary for Health to look at what else can be done or should be done to improve implementation. We've also formed a vaccine confidence or hesitancy, we haven't quite come out with the right name for it, working group, to try and deal with improving acceptance of vaccinations that are recommended. We have a global immunization working group that has proposed a comprehensive set of recommendations for why it's both in humanitarian interest and in our own interest to improve global immunization, ranging from use of current vaccines, regulation and development of new vaccines to deal with global infectious disease problems. And we also, as was mentioned earlier, have a set of recommendations we're commenting on from our maternal immunization working group to improve coverage, and our hope is to finalize those recommendations or vote on those recommendations at the September meeting.
Thank you, Walt. So briefly, so the themes of NVAC are often overlap with the themes of the National Vaccine Program Office under the umbrella of the National Vaccine Plan. As Walt said, I think one of the major themes really across that is adult immunizations, which he mentioned, and there's a significant effort in bringing this, transforming what was the National Influenza Vaccine Summit into now an adult summit with the help of partnerships with CDC and Immunization Action Coalition. That's been picked up by the Assistant Secretary for Health. There's an interagency task force focusing on adult immunizations. In the future, we're hoping to develop a freestanding adult immunization plan or strategy that somewhat maps across the goals of the National Vaccine Plan. So a lot of things related to adult vaccines. And then finally, the committee here has seen the presentation in the past from the Institute of Medicine looking at the vaccine prioritization decision-making algorithm they call SMART vaccines. They're in another phase now, and I think their report is scheduled to be released at the end of September. Whether or not you want to hear from them again in October, we'll see, but that will be that'll be public at the end of September. That's it for me. Thanks.
Thank you very much, Dr. Gillen. Is there any final comment from anyone? Last thing I need to mention is we start promptly at 8 o'clock tomorrow morning. We have no unfinished business, and we will get started with rotavirus at that point in time. And we are finishing up a good 10 minutes ahead of schedule, so thanks everybody for their succinctness.